Hello, everyone. Welcome to today's specialty testing webinar on AJCC 8th edition of lung cancer staging, emphasis on multiple lung carcinomas. Our presenter today is Dr. Marie Christine Aubry, Professor of Laboratory Medicine and Pathology and Head of the Pulmonary Section within the Division of Anatomic Pathology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function. If you are participating in the audio-only portion of this webinar, following the presentation, phone lines can be unmuted to ask a question. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn the phone over to Dr. Aubry.
Thank you very much, and thank you for joining this webinar. Today, the two major goals will be to review the changes to the new TNM of lung carcinomas, and a lot of the presentation will focus on the new TNM proposed for multiple lung carcinomas. So hopefully by the end of this lecture, you'll be able to describe the new t-test descriptors, especially as they pertain to what is called subsolid tumors. Know that the staging of multiple lung carcinomas varies with the clinical scenario, and that you will be able to recognize what these clinical scenarios are and what staging scheme to use. Understand the importance and limitation of pathologist interpretation in staging multiple lung carcinomas, but also understand the role and limitation of ancillary studies in that context. So we stage tumors, of course, as to determine the extent of disease that of a cancer that has some similar biologic behavior, and therefore can predict for a clinically relevant group of disease and help the clinician determine what is the appropriate treatment for these disease. With that in mind, a group of the International Association of Lung Cancer Study multidisciplinary expert added some guiding principles when they sat to go over what should be the new TNM staging for lung cancer. First, they tried to simplify the clinical and pathologic staging by choosing criteria that would match between both clinical and pathologic TNM. That means that basically, we can use radiologic information to inform the pathologic staging in some situation, and it can be very helpful. Also, it is important to know that in order to develop the new criteria for the TNM, this multidisciplinary team had a large data set of almost 71,000 non-small cell lung cancer, but it's retrospective data, and therefore there may be some missing piece of information for some subgroup, and that was particularly true for the subsolid lung cancers and the multiple lung cancers, and they had to use a lot of literature review to inform the staging. So really more of a consensus type of staging proposal rather than really data-driven. With that, on your left-hand side, the T descriptor listed is the prior TNM staging. So what has changed is, one, we'll talk about the carcinoma in situ. Historically, TIS for carcinoma in situ applied only to squamous cell carcinoma, but now we have adenocarcinoma in situ, and this is included under TIS, and we'll talk about that a little later. The T1 staging still remains as less than 3 centimeter and not involving the main bronchus and pleural invasion, but what has changed is the various subgrouping of the tumors by size. So now the T1A is 1 centimeter and less, the T1B is greater than 1 or 2 and less, and T1C is 2 to 3 centimeter. The T2 has changed. The maximum size for the T2 has gone from 7 centimeters to 5 centimeters, or any of the following. Pleural invasion remains the same. What has changed is historically for the involvement of the main bronchus, there was a division that occurred whether or not you were beyond 2 centimeter of the carina or within 2 centimeter of the carina. That has now gone away. As soon as the main bronchus is involved, it's a T2, no matter the distance from the carina. Same thing for atelectasis and obstructive pneumonia. It was divided between T2 and T3 depending on the extent of involvement by atelectasis and obstructive pneumonia, and that has changed. As soon as you have any degree of atelectasis and obstructive pneumonia to a hilar region or more, it becomes a T2. And now the subgrouping of T2A will be 3 to 4 centimeters and T2B 4 to 5 centimeters. For T3s, there is a limitation of size. It is from 5 to 7 centimeter maximum, or invasion into the parietal pleura or pericardium, that remains the same, chest wall, or a separate tumor nodule in the same lobe, and we'll come back to that later. Diaphragm has now been, involvement of the diaphragm makes it a T4, and any size tumor of 7 centimeter or more, and involvement beyond the diaphragm, also the heart, trachea, and esophagus, or a separate tumor nodule in an other ipsilateral lobe. So these are the new T descriptors for the TNM staging. For the N descriptors, there's no changes. So the N1 remains the same with metastasis in ipsilateral, peribronchular, or hilar lymph nodes, whether it's by direct extension or not. N2 is metastasis in ipsilateral, mediastinal, and or subcarinal lymph node, and N3 is metastasis in contralateral lymph nodes or supraclavicular scalene lymph nodes. What we'll see probably in the literature is a lot of studies to whether or not single or versus multiple stations should affect the staging. The team has looked at that, and they have noticed differences whether or not, for example, you have one end node involved versus if you have multiple end node involved. It does break out the overall survival, but they felt there was not enough data to make significant changes to the N descriptor, but this may change in the next iteration of the TNM classification. For the M descriptor, there's not significant changes either. M0 remains the same as no distant metastasis. M1 distant metastasis is divided into a M1A, M1B, and M1C. M1A, the main changes is now that as soon as you have an effusion clinically, you're M1A. You do not need to prove that there's tumor in your effusion. And furthermore, M1B has now been divided between an M1B and M1C. M1B will be for a single metastasis in a single organ for oligometastatic disease, basically, and M1C will now be multiple metastasis in a single or multiple organs. And this brings us to the multiple lung carcinomas. So as alluded into the introduction, the first thing we have to do now as pathologists is identify the various clinical scenarios that will lead to using a different staging scheme. And those 3 different clinical scenarios are, 1, the presence of multiple solid tumor nodules. 2, the presence of so-called subsolid nodules, and radiologists will talk about nodules that have ground glass opacities, or for us pathologists, it will be tumors that have a prominent lipidic growth pattern. And 3, pneumonic involvement. So we'll start with multiple solid tumors. Typically, it's usually 2, but it could be more, where you have different nodules that are entirely solid, as in this case. In that setting, before we stage these tumors, we have to determine whether or not we think that these tumor nodules are independent primaries and stage accordingly, or if in fact they're intrapulmonary metastasis and stage accordingly. So how do we do that? From a clinical perspective, And that means that we are not doing pathologic assessment that is called comprehensive, and I'll describe what that is. You could be considered separate primary tumors if, just by definition, you have either cytology or biopsy that indicates you have clear, defined, different histologic types. Specifically, for example, a squamous cell carcinoma versus adenocarcinoma. If they may be considered intrapulmonary metastasis, if they have exactly matching breakpoints on CGH array, and we'll come back to that. Relative arguments to favor separate primary tumors, and that means considering clinical factors such as radiology factors, rates of growth, or the presence or absence of nodal or systemic metastasis, or potentially different patterns of biomarkers. And finally, relative arguments, and I mean really relative, to favor intrapulmonary metastasis. On the flip side, they have similar radiologic appearance, similar growth rates, they have significant nodal or systemic metastasis, or they have a similar biomarker pattern. From a pathology perspective, this requires resection to allow us to do a comprehensive histologic assessment, and you could be considered separate primary tumors if not only your different squamous versus adeno subtypes, but within your comprehensive histologic assessment, you have two adenocarcinomas, but you believe that they are related or not based on morphology, or if you have a squamous cell carcinoma arising from a carcinoma in situ. And after that, it's pretty much the similar consideration for intrapulmonary metastasis using breakpoints on CGH, the relative arguments in terms of diffuse different patterns of biomarkers or no metastasis, or on the flip side, to favor intrapulmonary metastasis if you have a similar morphology or similar biomarker and significant nodal or systemic metastasis. So it's very important to emphasize, again, these relative arguments, which means to be used with caution, and we'll go into the details of that. So what do we mean by comprehensive assessment? This terminology was introduced by Giral and al. In the Journal of Surgical Pathology in 2009. It means first, of course, looking at the histologic subtype and determining if the broad categories are the same or not. But furthermore, in the case of adenocarcinoma, it's looking at the different patterns and proportion of patterns for adenocarcinoma, the histologic grade, the degree of cytologic similarity or differences or stromal features. Some of the shortcomings for that study is that there was no inter-observer comparison, in that the comparison was made basically between pathology and a non-gold standard was a molecular assessment, and which led a bit to a circular argument. But this being said, there's a lot of value in doing that pathologic assessment, but there's also some limitation. And I'm showing a table from a study that I did with one of my colleagues, Dr. Yi. So one of us is reviewer 1, and then one of us is reviewer 2. And we're looking here at the same tumor, tumor 1 and tumor 2, and we were trying to predict independently, without knowing what the other one was assessing, whether or not these tumors would be independent primaries or if they would be related. On average, we agreed with each other. However, there are times where we did not agree. So in this case, reviewer 1, looking at the two tumors, thought they were likely independent primaries, where reviewer 2, looking at the exact same tumors, came to a different conclusion. And of course, that is significant from a clinical perspective, but because in one case, one reviewer would have signed out their cases as these tumors being independent, where the other reviewer would have favored metastasis. So on average, in this situation, in this study, my colleague and I agreed almost 80% of the time, and that, of course, is in resected tumors. It doesn't apply to frozen sections or biopsies. But it also raised the challenges that we don't always agree. And in practice, what it means is that in these situations, we tend to share a lot of cases to see if we could come to an agreement, especially in some of the more challenging cases. So don't hesitate to share with colleagues to come to an agreement on whether or not you're favoring that these tumors look the same and therefore should be intrapulmonary metastasis, or if they look different enough that you should call them independent primaries. And this is other studies that have reported similar agreement, in fact, maybe little lower agreement of adenocarcinoma patterns. And that's something else that's important because we can't rely necessarily on the pattern description of a colleague, not because they're not accurate, it's just that we may look at the same thing, but we don't do the same interpretation. And that happens often. So the agreement varies between 50 to 60% on reproducibility of the adenocarcinoma patterns. And we saw that here too. So my colleague Jen Bolin with my colleague Joanne Yee did a similar study where they look at the individual patterns of adenocarcinoma, and then they even lump the patterns together under different grades and also look at the prognosis. And what that study showed, looking at 534 cases, is the exact match of the most predominant adenocarcinoma pattern occurred only in 52% of the time. When we looked at the grading score, they increased the agreement by 27%. So on average, they kind of were roughly in the same grading score or pattern in about 78 to 80% of the time, which left them with 21% disagreement. The good news is, even if we disagree, these are the independent survival curves. So even if they disagree, the survival curves break out pretty similarly. But it's important to emphasize that when you're looking at tumors, you should look at them yourself. So again, coming back to the study that my colleague Joanne Yee and I did, if you look at tumor to tumor, so this is tumor 1 that my colleague and I are both looking at it. We're looking at the same tumor again, the same sections. One reviewer thought it was predominantly cribriform, where the other reviewer shared about half and half solid and cribriform. So we're looking at the same tumor, but we're not actually classifying the adenocarcinoma pattern the same way. Same thing, tumor 2, I saw the tumor was acinar 50% and lipidic 40%, where only a little bit of papillary at 10%. My colleague looking at the same tumor thought that papillary was the predominant pattern. So what that means is if these two tumors are actually being resected at different times, when you make that morphologic comparison, one pathologist has to look at both tumors to make the final assessment as to whether or not they're related. Don't rely just on the written report to make that assessment. The gold standard still remains a morphologic comparison, although there are limitations to that gold standard. That is why we're basically trying to find ancillary studies that could help the limitation of that gold studies, of that gold standard. One thing that people have looked at is mutations. We all now do mutational studies on the lung cancer in advanced stage, and there's many studies that have looked, well, can we use, for example, EGFR mutational status to help us determine if these tumors are related or not. The problem is that, in general, these mutations have a high prevalence, even if they occur in different patients. So what that means is that you could have the exact same mutation in tumors of two different patients. So therefore, the tumors, you know, they can't be related. They are occurring in two different patients, but they have the same exact mutation. Similarly, people have found discordant mutations between primary and metastasis of same patients, and this is what this table reflects. So if you just look at the EGFR PCR data highlighted in these purple bars, what people have found is that there can be a high degree of discordance, in this study up to 70%, which is probably too high, between a primary and a metastasis. But these studies are pretty old, done with PCR. If we look at now, what we do often is next generation sequencing, and we looked at that. We looked at tumors that we classified as independent by two methods. One is the pathology reporting and the morphologic assessment, and one is by a new generation, next generation sequencing method that I will describe briefly. But suffice to say, these tumors were classified as independent primary, and these tumors were classified as related. The first thing to know is there are some limitations if you just look at driving mutations, because not all tumors are informative. For example, in this case, both tumors in this patient did not have any driver mutation. So this test would not be helpful in determining whether they're related or not, because they don't even provide you any information. And it happens quite often. You find a driver mutation about 30 to 40% of lung cancer. But even if you do find a driver mutation, this is a perfect example where KRAS mutation, we had the exact same mutation in tumors that were considered independent. So you can't use that only to determine if they're related or not. Similarly, in this case, these tumors were considered related, and even if they were considered related, they actually had a different mutation. So you have to be careful using mutational status of driving mutation to help you in determining if these tumors are related or not. So in our summary of our cases, we actually had 44% of our cases that were non-informative because it didn't have any driver mutation, which fits well with what we expect. 4 actually had the same mutation, although they were independent primaries, and the opposite is true. So just beware. It can be helpful, but you have to really put it in the context of a lot of other findings. And at the end of the day, pathology assessment is very critical to this step. So that addressed the relative argument and why they made this a relative argument in terms of biomarker patterns for helping you determine if these tumors are independent primaries or intrapulmonary metastasis. Now, this is a little stronger. They didn't say relative arguments. They actually said may be considered intrapulmonary metastasis if they have an exact matching breakpoint on CGH array. What do they mean by that? Well, first we have to define what are breakpoints. So basically, breakpoints occur when you have genomic rearrangement. So if we take the example of ALK rearrangement, which is one of the rearrangements we see in lung cancer, when there's a rearrangement, the animation didn't particularly work, but this is an inversion where actually your ALK will invert and rearrange itself with the ELM4 in this example chromosome. And the breakpoints are really the area of the chromosome where the chromosome had to break itself to be able to rearrange. So you'll find breakpoints in any type of rearrangement. This is an example of an inversion, but it can occur also in translocation, in deletions, are all examples of rearrangements. So the breakpoint is the exact place on the chromosome where you are having a break to be able to rearrange. Now, we know that breakpoints are unique to a tumor and they are unique to a patient. So even if you have a rearrangement like ALK that occurs on the same chromosome and even in the same gene, it does not occur in the exact same base pair. In fact, we calculated the relatedness to this level. And on top of that, breakpoints are interesting in that it doesn't need to be in a driver gene to be informative. There's always hundreds of breakpoints that occur in a tumor just because of the complexity of becoming a tumor. So we use actually this information, and we are able to assess this information using MAPAIR sequencing. And MAPAIR is a technique that is used only at Mayo Clinic right now that allows us to identify all breakpoints in any type of chromosomal rearrangement across the whole genome, and it occurs over a 200 to 500 base pair, so at a very small area of the chromosome. And using that technique, we actually looked at tumors that we knew were independent primaries because they were of different subtypes, and that we knew they were metastases because they were adenocarcinomas of the lung, metastasis to the brain or to the kidney, so outside the lung. And these are all the breakpoints that occur within one tumor and the second tumor within one patient. And the hypothesis, if you're not related, you should have no breakpoints in common. And if you're related, you should have breakpoints in common. And the blue bar indicates the breakpoints that are in common. But as you are progressively becoming aggressive, you will acquire new breakpoints. It's just part of the heterogeneity of cancer. But in our study, all tumors that were related had breakpoints in common, and when they were not related, did not have breakpoints in common. And that was very helpful for us when we started looking at tumors that had similar morphology and trying to determine whether they were related or not. And we just ran a lot of tumors that were of the same histology in two different locations and started looking what were the rearrangements and breakpoints that were not in common or in common between these tumors. And we also compared to the pathologist. So basically, these are cases where my colleague and I agreed that they should be intrapulmonary metastasis, and this is the cases where we agreed that they should not be intrapulmonary metastasis. And in the cases that we did agree they should be metastasis, every single cases had some breakpoint in common. And the opposite occurred, where when we didn't think they were metastasis, we did not find any breakpoints in common. Of course, as I mentioned earlier, my colleague and I did not always agree. These were the 6 cases where my colleague and I did not agree, and therefore, in some cases, the genomic data agreed with one of us. These are 2 cases where my colleague and I thought they should be intrapulmonary metastasis, but the genomic data showed otherwise. And the clinician, based on their criteria, would have considered these independent also. They agreed with the genomic data. So basically, this statement was based on our data where they say that exactly matching breakpoints could point toward tumors being intrapulmonary metastasis. However, we did not use CGH array. We use a different method, which is mate pair sequencing. And that is important because basically CGH array has a much lower resolution than mate pair sequencing, and it's not sensitive enough. And what we mean by that is if you use OncoScan as a technique, the resolution for driver's gene is 50 kb, and for non-driver genes, 300 to 400 kb, where with the mate pair sequencing, we're talking 300 to 500 pair base. So a very significant difference in the resolution for mate pair. So you may easily find 2 breakpoints that are within 300 to 400 kb, but yet are not within the 500 bare pace. So you can make a false call just looking at CGH array. So again, I would use that technique as an additional piece of information, but not the only piece of information. Now, looking again at next-gen sequencing, with next-generation sequencing, you can actually assess for rearrangements. But again, there's limitations by that technique. This is an example of a case where actually they were related by the genomic data and by comprehensive data, but they had actually a different rearrangement within the RET gene. So there are very challenges in determining the lineage between tumors. In summary, pathology remains key. So we play an important role as pathologists in using as best as we can the morphology to help us determine whether these tumors are independent primaries or related. After that, you start adding a lot of other additional information, but always being very critical of that information. Biomarker profiles may be helpful, but they have strong limitations. The same thing with breakpoints. They're ideal, but the technique we use right now clinically has some limitations. So if now you were at a stage where to the best of our abilities, we have determined that the tumors are independent primaries. If we say that, then the staging hasn't really changed. You really stage a tumor independently using the TNM criteria as outlined earlier. If they're considered metastasis, there's no changes from the prior edition. If you are two tumors in the same lobe, you're T3. If you're two tumors in different lobe on the same side, you're T4. If you're two tumors, two nodules on different side, you're M1A. Let's switch to the second clinical scenario, which is multiple nodules with ground glass or lipidic features. First, we have to address the ground glass subsolid nodule situation. So what are subsolid nodules? There are nodules that could be anywhere from pure ground glass opacities on radiology to nodules that have parts that are solid and parts that are ground glass opacities. And what does that equate to us pathologists? Usually, not always, but usually pure ground glass opacities radiologically are adenocarcinoma in situ. They may include minimally invasive, but usually the minimally invasive adenocarcinomas, since they have a little component of solid growth or invasive growth, may be detected radiologically. But lipidic predominant adenocarcinoma or adenocarcinoma that have a lipidic growth usually are falling under the subsolid with a solid pattern in a partial ground glass opacity pattern. So basically, these are your subsolid nodules. And for pathologists, again, it's adenocarcinoma in situ, minimally invasive adenocarcinomas, or lipidic predominant adenocarcinomas. The new TNM staging applies only to these subsolid nodules that are non-mucinous. It does not apply to the mucinous. And the reason for that is they had to use published data to make this consensus statement, and most of the published data right now applies only to the non-mucinous tumor. We do not have enough data in the literature to make extrapolations to mucinous tumors. So if you have mucinous tumors that are lipidic, this TNM classification does not apply to them. It applies to only the non-mucinous tumor and also applies to the non-mucinous tumors that are 3 centimeter or less. So if you have in situ tumors, if you have an adenocarcinoma in situ, you use TIS and then you put between brackets the abbreviation AIS to distinguish from the squamous cell carcinoma in situ that will have a TIS with between brackets SCIS to identify squamous cell tumors. If you're a minimally invasive adenocarcinoma, your T is T1MI to reflect minimally invasive. If it's a lipidic adenocarcinoma, your T is based on the invasive component. You measure what is invasive. You do not include the lipidic growth pattern in your measurement to determine the T staging. You still report the overall size, but your T is based on the size of invasion. And even if you have not a lipidic predominant, as soon as you have a lipidic component, you still don't include that lipidic component in the overall T size, only the invasion. You record the overall size, and if you're having trouble determining what is the overall size, you can use CT scan to guide you. To a certain extent, you could potentially use the CT scan to guide your size of invasion. Again, I would be careful. There's not a perfect correlation in the studies between pathology and CT scan size, but it can be very helpful, and I would use that information. The radiologists are held to the same standard. It's not going to be easier for radiologists, this TNM staging, when they do the clinical, but they have the same criteria in terms of assessing really what is solid from what is ground glass opacities, which is the same equivalent to us between what is invasive versus what is non-invasive. And then the size of the invasion would determine if it's a PT1A, PT1B, or PT1C. So how good are we to agree on invasion? We are not very good, and we know that. It's well studied in the literature that in easy cases, we agree with a kappa of 0.55, and in difficult cases, our kappa is very poor with 0.15. So what does that mean in practice? That means in practice that there will be disagreement, and in any situation, we share a lot of cases amongst each other because we don't agree with ourselves here either. So these are cases where you share to try to come to a consensus on the best size of invasion because there will be challenging cases. So this is a study from our institution where we actually look at that correlation between two raters. On average, we agree pretty well, but it's about 80%. The good news is when we disagree, it's in categories that are closely related because going from an MIA to an IA, we're talking 1 millimeter differences. The same thing, going from AIS to MIA goes from 0 to 1 millimeter. But when we disagree, it's at least with categories that are similar to each other. And again, the survival curves break down pretty nicely even if there are some disagreements. So when in doubt, when you're struggling with a case, just share, correlate with the imaging, and try to come to the best consensus for that overall size because that size of invasion really determines your TNM staging. What if you have subsolid nodules, but the tumor size is greater than 3 centimeters? Everything that we have described does not apply. As a rule, if you have no invasion or invasion of less than 5 millimeters, you do not use AIS or MIA. It becomes an automatic T1A. If you have mucinous adenocarcinoma, no matter what the invasion size is or the amount of lipidic component, you use the overall size for TNM staging. Now, what if you're in the situation where you have multiple of these nodules? We have a different staging system because we have recognized that the epidemiologies of these multiple ground glass opacities are different from the solid nodules that we just described. They're commonly multifocal, so we're seeing these more and more with CT screening. They're often women, never smokers, and they have a different biology. They recur locally, they don't recur distantly or with lymph nodes typically, and they have an excellent outcome. Furthermore, their morphology is so similar that we can't use the same criteria as described for the comprehensive morphologic features to distinguish independent primaries or not, and there's not enough clonality studies on these tumors to use for staging. So the group from the International Association of Study of Lung Cancer devised a separate staging system for these tumors. And what they recommend, and what we do now, is you do your T staging according to the highest T grade. And then this will be followed by the number of lesions in between brackets after that T staging. And if you can't count the lesions, they're too numerous, you could use M for multiple. And it doesn't change whether you're ipsilateral, different lobes, or contralateral. And if there happens to be a lymph node metastasis or happens to be a distant metastasis, which should be the exception, it's a collective N and M for that staging, and you really have to correlate with imaging in that circumstance. The reason is you may be at the bench at the frozen section and you get one subsolid nodule that's resected with a wedge. Your tumor measures 1.5 centimeters overall size, but under the microscope, it's a lipidic predominant, there's a 6 millimeter invasion. And if that's all the information you're looking at, you're going to make a staging of PT1A and XMX based on this information. What you need to do now, you have to go back to the imaging, because what you'll see is, well, I have a pure ground glass opacity here, and the tumor that was resected is actually this tumor here that had a subsolid component. And in that setting, actually you have more than one nodule. And in fact, you could argue that there's probably a different nodule here and maybe even a different nodule here of ground glass opacity. So your staging changes. Really, your correct staging is PT1A, but in between brackets, you have recognized that there's multiple tumor nodules, and your assessment from the radiologic note is that they resected the tumor nodules with the greatest solid size, and you still don't know your N or your M based on the material given to you. So that's how you use the radiologic information to inform your staging in this clinical context. And lastly, the pneumonic type of lung cancer. That's the easiest because there's not a lot of change from what we have been doing. But we just recognize that some lung cancers present not with a well-defined mass, but more with what they call a pneumonic infiltrate. So it looks like a pneumonia radiologically, or just kind of a vague consolidation, which may be in multiple lobes or confluent within one lobe. So the radiologists and clinicians have their criteria. From a pathology perspective, what we're dealing with grossly, we have diffuse infiltrates or a diffuse, vaguely demarcated nodular area of consolidation. Most of the time, these tumors will be mucinous. That's the most common scenario. And they could have all sorts of patterns, but they will usually be mucinous adenocarcinoma. And this is a nice example where, from a radiologic perspective, often the first diagnosis patients will get will be pneumonia, or they'll have a descriptive radiologic diagnosis of consolidation. Eventually, this is not going away with treatment, or it may be progressing. The patient may get a needle biopsy, a diagnosis of adenocarcinoma is made, and then that's when the resection occurs. And grossly, what we have is this is actually the normal lung, and this is the abnormal lung that has kind of this diffuse, confluent, mucoid type of looking consolidation. And under the microscope, like I said, these tumors will often be mucinous in nature. And this is what we call pneumonic type adenocarcinoma. And the staging is that the reason there's a different staging is it's recognized that size is difficult to ascertain, both for the radiologist and both for the pathologist. And in that situation, as long as there's that tumor, even if you have not a well-defined size, you can't say it's 1 centimeter, but it just diffusely involves the entire lobe, then you call it a T3. And if it seems to involve 2 lobes within the same area without being able to give it a very well-defined size, you'll call it a T4. And if it's bilateral, you'll stage it as a M1A. And again, correlation with imaging may be necessary in that situation to define the appropriate clinical scenario. So the take-home message. When you're dealing with multiple lung tumors, you first have to define the clinical scenario. You're either dealing with multiple solid nodules, or you're in the setting of multifocal ground glass or lipidic predominant nodules, or finally you have a pneumonic type of adenocarcinoma. If you have 2 solid nodules, the first thing as a pathologist you have to do is to determine the lineage of these tumors. Are they related and therefore intrapulmonary metastasis, or are they independent and therefore independent primaries? Pathology plays an important role, has some limitation, and therefore that is why these tumors are often discussed in tumor boards to use other criteria to help make that decision, but recognizing that most of the additional metrics are also imperfect. When you are dealing with ground glass opacities, subsolid nodules, this TNM staging applies only to non-mucinous tumors that are 3 centimeters or less, and the T is based on the size of invasion, not the overall size. In that clinical scenario, if there are multiple, the T is based on the highest T of all nodules, whether histologic or radiologic. So this is the context where you have to know the radiologic findings. Usually the surgeons, if they resect these nodules, will resect typically the nodule that has the most solid component, because those are the ones that are more worrisome clinically. And then in that, you add the number of nodules between brackets or M to your T staging. For the pneumonic type, this is the one that has an infiltrate. It's not well demarcated. It's hard to measure whether radiologically or grossly. And then the T is based on the extent of involvement of one lobe, multiple lobes on one side, or different lobes on different sides. And there's a lot of people that can help here at Mayo Clinic and are always happy to answer any questions by email or otherwise in terms of dealing with these challenging situations. And I want to take time to thank my clinical colleagues and research colleagues that are helping to clarify, hopefully, this difficult scenario of multiple lung cancer. And with that, if you have any questions, I'll turn it over to Carrie.
Yes, thank you, Dr. Aubrey. At this time, we would like to take any questions that you may have. If you would like to ask a question, please submit through the chat function on the CenturyLink web application. For participants joining in the audio-only portion of the webinar, press *7 to unmute your phone. Once you have finished asking your question, press *6 to mute your line again. Okay, the first question. Dr. Aubrey, can you discuss how to distinguish between lipidic growth from invasive growth when measuring the invasive component?
Yeah, that is a very challenging situation, and I kind of addressed that a little bit. I'm going back in my slides to try to get to one slide that shows a bit the measurements and what are the challenges in measuring the growth of tumor and separating invasion from lipidic. So I think I highlighted that even experts don't agree, and if you look at large groups of pathologists trying to measure, they don't agree either. So I think hopefully that brings some kind of comfort, and that's why sometimes more than one head is better in determining the size of invasion. So basically, what constitutes invasion? What we try to use for criteria is anytime you see a little bit of a scarring, be very sensitive that you may have invasion. And that's kind of important. And then when in doubt, sometimes, even if we're like, I can't pinpoint to an area that I think is invasive, but I'm in a scar area, we tend to measure that scar. The danger is more understaging than overstaging in lung cancer because lung cancer behaves poorly. So I would not hesitate if you have to choose between overstaging a little to go that direction while trying to stay as much as accurate. When you have very small glands, and if the glands start having irregular shape, if you start seeing desmoplasia, those are features that we will call invasive. That's one thing. Anything that's papillary, it's an automatic invasion. Anything that's micropapillary, it's an automatic invasion. Those are features of invasion. Really, the debate is between a pure ground glass growth, which is obvious when the architecture is intact, versus separating something that may be, is it truly an acini indicating invasion, or is it more of a architectural remodeling where it's still lipidic, but it's kind of entrapped in non-specific scarring? And really those are the scenario. Anything else that is not acinar versus lipidic, it's automatically considered invasion. And whether you're determining if it's truly acinar versus lipidic, very small glands, glands that have irregular shapes, and if the stroma starts looking desmoplastic, just consider invasion. Areas that have a lot of scarring, be really concerned that you're probably dealing with invasion in this area. If you have multiple areas of scar and that's what happened, the recommendation is to either measure the largest area of invasion and count that as the overall invasion for your tumor, or some people will actually kind of give an estimate. So they'll look at overall tumor and they'll say, well, 90% of my tumor is really lipidic and my tumor measures 2 centimeters. So if I do 90% of or if I do 10% of 2 centimeters, that will be my invasion size that I will use. And that also is kind of described in the WHO as a way of doing it. So I think hopefully that answers that question.
All right. Thank you, Dr. Aubrey, for today's presentation, and thank you to the participants for joining us for this specialty testing webinar. If you have any additional questions, please indicate them on the evaluation that will be forwarded to you shortly. Please note, laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. And one additional note is to mark your calendar for the upcoming 22nd International Surgical Pathology Symposium, September 25th through the 28th in Venice, Italy. Additional information can be found on the Mayo Medical Laboratories website. We hope you can join us. Thank you again for joining us today, and have a great day.